Well, I want to thank you so much for that very kind introduction and for the organizers of the conference for inviting me to speak. I'm really excited to talk a little bit about HIV and cardiovascular disease. I'm also so sorry I can't join you in person. These are my disclosures. And I want to think about what is the burden of cardiovascular disease and HIV. So the first case was described here in 1990, and 28 years later in 2018, we know from this meta-analysis that people with HIV are twice as likely to develop cardiovascular disease, and the global burden has actually tripled in the past 2 decades. So in today's talk, I'm going to touch upon some topics, including hypertension, heart failure, sudden death, lipids, inflammation, and management for ischemia as well. I want to start out with the patient case. This is a patient that presented, was found to have heart disease, and was referred for a bypass surgery. But I want to say in his care, there are many areas of breakdown. Let's say he didn't show up. If he didn't want to have surgery, he may not have come to clinic. The surgeon may not have wanted to perform the operation on him. Maybe the tests weren't done. There are many, many social issues, but he got surgery against all odds. This really focuses on the importance of care for cardiovascular disease and HIV. In 2005, I started the first clinic looking at cardiovascular disease and HIV infection, and this has really evolved over the years. So this is now the Golden Compass Clinic in San Francisco. It provides multidisciplinary care for all older persons with HIV aged 50 and older. So not just cardiology, but also pulmonary, neurologic, and geriatrics. And this clinic has really served as a prototype for other clinics around the country. Let's talk a little bit about blood pressure. Let's think about now in the United States over the past 20 years, what do people think? Is blood pressure control getting better, not changing, or getting worse? And so this was a surprise to me when I was researching for this talk. And this is a recent study looking at blood pressure control in the United States in about a mean age of 38, showing that the prevalence of controlled blood pressure, including the newer guidelines, is actually decreasing in more current times. And so that's a surprise, an important reminder to all of us clinicians that we really got to watch blood pressure. So I'd also like to start out with a patient case. This is a 59-year-old gentleman with HIV. He's treated and suppressed on Biktarvy. His blood pressure is shown there, LDL of 92. And I want to ask the audience, what is your goal for this patient? Should you start meds? And so I have a variety of different answers shown here. Let's think about this. So the categories of blood pressure are shown here. Normal is now less than 120 and diastolic less than 180. Stage 1 is now 130 to 139 with a diastolic over 80 to 89. And so if you look at this, this shows that the definition of hypertension is lower, and 46% of individuals will have hypertension. This will actually triple in younger men and double in younger women as well. But with respect to adults requiring medication, this is really only a small number of individuals, even with the new guidelines. So if you look at different thresholds for blood pressure, for many people with additional risk factors like kidney disease, heart failure, or coronary disease, there will be lower blood pressure thresholds like 130 over 80. The guidelines have now been simplified, and they show for many individuals who have this blood pressure 130 over 80, you should try to calculate or estimate their cardiovascular risk in the next 10 years. And that will decide who can get blood pressure medication versus not. So when we go back to our patient living with HIV, we really have to calculate his cardiovascular risk. And we know, I think all of us who've been studying this, knowing that the traditional risk calculators do not perform well on HIV. They tend to underestimate risk, particularly at intermediate and higher risk individuals. And the HIV specific calculators have really had mixed uptake in the population. And this is because they really only focus on known pathways. They don't take into account antiretroviral therapy or chronic inflammation. So with regards to risk, even though it's not ideal, I tend to use the ASCVD risk and the Risk Estimator Plus. You can get this online, and it provides a nice individualized approach to manage cardiovascular risk, a 10-year risk and also a lifetime risk as shown here. So if you punch in that patient's number, you can see that he has a 10% 10-year risk, and his lifetime risk is actually 36%. And you can also look if you controlled his blood pressure with medication, what that risk will translate to, as well as statin therapy. So back to this patient, we calculated a risk, it's 10%. So with regards to answers, you should calculate his ASCVD risk, and his blood pressure guideline will be 130/80. And so basically the bottom line is non-pharmacologic, so diet, exercise would be recommended for all individuals, and target blood pressure for those requiring blood pressure medication is usually 130/80. So I love this study that was done looking at African-American barbers and their interaction with patients to control blood pressure, showing outstanding intervention and lowering of blood pressure with this community intervention. Really like to think about if and can we design something like this for HIV infected individuals. And of course, in underserved populations, this has been studied as part of the SEARCH study, which is a large population-wide study to really screen for HIV. And they're now looking at comorbidities, looking at blood pressure control, showing that you can improve hypertension control. I now want to turn a little bit to heart failure. And this is a second patient case, a patient with poorly controlled HIV infection, drug use, presenting with heart failure. Here's his echocardiogram showing the pumping function. You can see terrible pumping function. This is an LV clot. So HIV infection has been associated with all types of heart failure, reduced ejection fraction and preserved ejection fraction associated with worsened HIV disease. More recent studies have suggested that potentially protease inhibitors, as shown in here, are associated with heart failure risk. Obviously, overall as a field, we don't quite understand the mechanism of why HIV causes heart failure. Is it from chronic inflammation or antiretroviral therapy? I want to go back to that patient and say, what kind of medications should you use? And this, again, is not something that necessarily I would expect the general population to know, but it's important to hear about this because there's been many changes about these medications in the past several years. And so these are some guidelines for the general population. So patients who have structural heart disease with prior or current symptoms of heart failure, and so even if they have no limitation of physical activity. So the guidelines done about almost 9 years ago and more recently show that all patients should be on an ACE inhibitor or an ARB, as well as a beta blocker and diuretics. And there are special considerations for special populations. Now, this has really changed in the past couple of years. There's a new agent called Entresto, which is also called sacubitril/valsartan, as shown here. It's a combination angiotensin receptor blocker, as well as neprilysin inhibitor. And so this is important for people to know about because in the general population with heart failure, there is a significant reduction and improvement among patients who are on Entresto versus ACE inhibitors, such as enalapril. So we really now use one of the three following agents, Entresto, ACE inhibitor, or angiotensin receptor blockade. And the indications are really reduced ejection fraction symptoms, and you should give it with other medications. So now for individuals with heart failure, the current guidelines say that all individuals should be considered for Entresto or an ACE inhibitor or an angiotensin receptor blocker. And so I want to focus a little bit on the Entresto arm. Remember that patients should not be on an ACE inhibitor or an ARB when starting Entresto. You should stop it 36 hours ahead of time. And these newer agents can actually cause patients to have a very rapid diuresis. So you have to watch that. You also have to watch kidney function. I want to mention some newer agents that are diabetes agents that have been shown to be incredibly tremendously effective in the setting of heart failure. So the SGLT2 inhibitors, as well as the GLP agonists as well. And with regards to heart failure, individuals should also be on an SGLT2 inhibitor. I want to focus a little bit more on that on the right-hand side. These are patients with reduced ejection fraction and symptoms as well. They do have side effects. They should not be used in patients who have type 1 diabetes. They can increase the risk of genital infections, and they they should not be used in patients with reduced renal function. So what about patients who have a preserved ejection fraction? So their ejection fraction is normal, but they have symptoms. So for many years, this HFpEF, or heart failure preserved ejection fraction, has been found to be higher in the setting of HIV infection. These are some older studies from our group, as well as other groups as well. And so usually for treatment, there's less medications available for this. In the past, we said the patient should be treated with blood pressure control, exercise, and weight loss. But there's some new pharmacologic therapies that should be considered, such as Entresto or these diabetic agents. So what about Entresto in heart failure preserved ejection fraction? There is a suggestion of benefit in some of the studies in the general population. This is currently being studied now. And similarly, the diabetic medications, the SGLT2 agents, there are studies showing that they improve clinical outcomes in the general population. So empagliflozin versus placebo here in the EMPEROR study. So back to that patient case, I will say that that patient with heart failure should be on all of these medications, including an aldosterone antagonist. And it's again, not that general practitioners or HIV physicians should know this, but because you are many of the individuals who take care of persons with HIV firsthand, I just thought it was important that people should hear about this as well. I think I'm gonna skip this study on atrial fibrillation. So what's new in sudden cardiac death? A study by our group now more than 10 years ago showed that patients with HIV over time, you can see here 2001 to 2009, they're more likely to die of AIDS, as shown here in blue. But what was surprising was that sudden cardiac death, as shown here in red, was more than fourfold higher than the general population. We don't really understand why that's the case. Let me skip this slide. Our group did a follow-up study to our original study that was just published in New England Journal last year, doing a very comprehensive review of medical records, EMS reports, autopsy, toxicology, and review of all clinical parameters. Here, over this time interval from 2011 to 2016, we identified 610 persons with HIV, 109 were unexpected, and 108 of these individuals underwent autopsy. When we underlooked at the cause of death, what was surprising was that occult drug overdose happened in 1/3 of those cases, which was higher than that of the general population. When we looked at presumed and also autopsy-defined sudden cardiac death, we found that this was 86% higher in HIV than the uninfected population. This was driven by findings in Caucasian men. And then what was special about this study is we had the histologic analysis of the heart. And here is staining and an quantitative evaluation of fibrosis. You can see the trichrome staining in blue. And overall, we found that in the hearts of persons with HIV, there was higher levels of total fibrosis in the patients with sudden death, as well as non-sudden death. And this was driven by interstitial fibrosis primarily. So I want to go to a different patient case, a patient who is treated and suppressed with hypertension, hyperlipidemia, and diabetes. He has an ECG finding showing depression and a troponin, and he gets a stent. So I want to say, what do you think is true regarding statins? Do statins reduce inflammation? Do all patients benefit from statins? Do patients who lower both the cholesterol parameters and inflammatory parameters derive the most benefit from statins? And is HIV considered a risk enhancer for cardiovascular disease when you're thinking about who should start statin therapy? What about injectable meds? So let's talk about lipids in HIV. We know that all patients with cardiovascular disease should be on a high-intensity statin. Some patients will have high cholesterol risk. Some patients will have high inflammation risk. Where do we think HIV-infected individuals should lie? I'd like to start on the high inflammation risk. In the general population with HIV, we know that patients who should be on statin use, that this is still underutilized in the setting of HIV infection, and even more so in the setting of co-infection. With respect to contraindicated medicines, you can see over time that statin use and protease inhibitors, there were fewer contraindicated statin use among HIV-infected individuals that decreased over time. You can see that with cobicistat use, that this has increased over the last couple of years from 2015 onwards. And with regards to statin studies, we know that they lower LDL cholesterol, as we know they would in HIV, but interestingly, they've had very mixed to little impact on inflammatory markers. So we still don't know if statins will lower those pathways of inflammation that we know are important in HIV infection. And so the only study that has shown that statins are not effective is this study called the Aurora study, which looked at rosuvastatin use in the setting of patients undergoing hemodialysis. So this is the only patient population in which statins do not demonstrate clinical benefit. With large statin studies in the general population, so this is both prove it and improve it, we know that individuals who can lower both their LDL cholesterol as well as their inflammatory markers, as shown here in red, achieve the most clinical benefit. And what's interesting is that now 17 years ago in 2005, we thought that statins for treating coronary disease, that was going to be as good as it gets. So we know in the general population that inflammation and also LDL are strongly predictive of cardiovascular risk, and that in the general population, statin lower both of these parameters. Here are the United States guidelines of who should be on a statin therapy. And you can see here, so for the first time, they're saying that individuals with HIV should be considered as a risk enhancer. So if you have a patient who is at like intermediate risk, you could consider HIV as something to favor statin use. In fact, I think there's lots of studies to show that HIV may be considered a risk equivalent. If you look at the European guidelines to start statin therapy, that individuals who are very high risk are targeted to have a lower LDL cholesterol 70. And they say that actually, where would patients with HIV be on that spectrum, and how are we going to get there as well? And so studies showing then, again, that HIV has a strong association with cardiovascular risk, similar to that of very potent traditional risk factors. So now there are very new medications for lipid lowering on the horizon. So I'm talking about PCSK9 inhibitors, which are injectable medications, as well as inclisiran, which is a silencing RNA agent that's injected now once every 6 months. In the general population, we know that these agents significantly reduce cholesterol as well as cardiovascular events. They have been studied in HIV to show a significant reduction of LDL. There are no drug-drug interactions, so it can be beneficial. And our group and others are doing studies to look at the role of PCSK9 inhibition in HIV and the impact on non-calcified plaque. So more recently, a newer agent called inclisiran has been studied to show significant reduction in cholesterol, as you can show here in the general population. And this is injected now once only 6 months. And so, in the future, will these just once or twice a year injections improve cholesterol? Will this improve adherence in the setting of HIV infection? So back to our patient case, statins reduce inflammation in HIV. I would say unproven. All patients benefit from statin use. This is false. This has not been shown in the case of hemodialysis. Patients who lower both LDL and CRP derive the most clinical benefit. This is true. HIV is considered a risk enhancer to start statin therapy. And injectable HIV meds and lipid lowering, this is in our future. So I want to point out there are other lipid lowering therapies that have been studied, including bempedoic acid on the bottom, as well as icosapent ethyl for high triglycerides on the top there. So now I want to go back into the right-hand side and look at residual inflammatory risk. And go back to our patient case. And what do we think? Lower inflammation reduces cardiovascular events in the general population. True, false? What about the use of colchicine in this setting? Colchicine does not lower ischemic events. True, false? What about colchicine in HIV? So we've talked a little bit about statins in the inflammatory pathway that impact down here, CRP. And then there are other agents such as low-dose methotrexate, and then agents that target things like IL-1 beta, like canakinumab, that may have a more potent impact on inflammation. We know in the general population that canakinumab, which is a monoclonal antibody to IL-1 beta, significantly reduces cardiovascular events, as well as surprisingly significantly reduces cancer, as well as cancer mortality. In a small study in HIV, our group has studied canakinumab to show significant reduction in arterial inflammation as well as bone marrow activity, as well as a significant reduction in CRP, as well as a 30% reduction in IL-6. What about methotrexate? So in the general population, methotrexate did not have a significant impact on clinical events or inflammation. And similarly, in a study in HIV, low-dose methotrexate reduced CD4 T cell count slightly, had a significant reduction in CD8 T cell count overall. There's no impact on inflammation. I talked a little bit about colchicine, and this is something that impacts the NLRP3 inflammasome. It's kind of not expensive, and we have decades of experience with this medication. So in the general population after MI, colchicine was found to significantly reduce clinical events by 23%. They only had biomarkers available in a subset of individuals. And now in patients with chronic coronary disease, colchicine was found to significantly reduce cardiovascular events. They did not study inflammatory markers in this study. What about colchicine in HIV infection? This has been studied in a small group to show no impact on inflammatory markers or vascular dysfunction. So back to our patient case, I want to say lowering inflammation reduces events in the general population, true. Colchicine does not lower ischemic CVD events in the patients with MI. This is false, it does. Colchicine lowers inflammation in HIV. From a small study, this was false. So finally, a final case, a 45-year-old gentleman with HIV who's treated with ART. He has a CT scan showing a blockage in his LAD, but he's excellent exercise tolerance, doesn't have symptoms. How would you treat this patient? Should we take him to angioplasty and stent? Should we change his HIV medication? Should we place him on medical therapy for CVD? So what do people think? If we revascularize him, either with a stent, will that help with his symptoms? So the ischemia study now was published 2 years ago, looked at in the general population, should we intervene on patients who have evidence of coronary disease, but are stable symptoms? So this is not in the setting of an acute MI. This is a very expensive, large study. And they found that, interestingly, studying over 8,000 individuals, that there's no difference at all between patients who went for angioplasty stent versus optimal medical therapy. That actually medical therapy is the mainstay of treatment in patients with stable coronary disease. So this was a huge study showing that doing catheters and stents in the setting did not reduce cardiovascular endpoints. It only had some effect on reducing symptoms. And they were wondering, like, if we looked at other high-risk populations like kidney disease, will this be beneficial? And this was not the case. No difference at all in patients with kidney disease. So we go back to our patient case. So remember, he has evidence of a blockage, but no symptoms. So cardiac cath and angioplasty and stent will make him live longer? False. His HIV regimen should be modified. I'm going to say this is unclear. He should be placed on medical therapy for CVD, definitely. Revascularization will help with the symptoms, true. So this is a new study that was just published last year showing again, now HIV infection is associated with abdominal aortic aneurysms. People with HIV had a fourfold higher odds of abdominal aortic aneurysms versus control. Things like age, obesity, and hepatitis B co-infection were associated with higher odds. And so I think this is very interesting. We're seeing more and more HIV associated with new cardiovascular conditions. So today I've talked a little bit in the last 20 minutes or so about these different items. On the right-hand side, we've also talked about some ways to treat cardiovascular disease and HIV, looking at lipid lowering, inflammation, targeting traditional risk factors, and I think in the future, HIV-specific strategies. So in summary, seeing a difference in the spectrum of cardiovascular complications in the setting of HIV, pre-ART, things like dilated cardiomyopathy, in the protease inhibitor era, coronary artery disease, now with heart failure, and who knows in the future what this will bring. This is a nice scientific statement on how to prevent and manage cardiovascular disease in persons living with HIV. Please email me for any questions, and thank you so much for your attention.